to dyslipidemia management this evening, and we are privileged to have with us Dr. Bill Simpson. Bill is a retired biochemist from the Clinical Biochemistry Department in Aberdeen. He is a long-standing trustee of SHARP and a previous chairman of SHARP, amongst many other international roles that he has played over many years, and he's been a very active member of SHARP. In fact, Bill was the founder, one of the founders of the Scottish Lipid Forum, which we co-host alongside SHARP. So it's a privilege really to have Bill here with us. Bill's now retired, so although I can see that he's back at work, he's been pulled back. They can't let go of him in Aberdeen, but he's now retired, so he's had a little bit more time than he otherwise would to enjoy the finer things in life. But Bill, thank you once again for agreeing to speak to us on a very intriguing topic of grandma, what a big cholesterol you have. So I'm very keen to hear what you've got to say about this. Just a few housekeeping rules. Could you please mute your microphones and turn your cameras off until the end of the presentation? And if you've got a question, please feel free to either type it in the chat or raise your hands, and you can ask the question to Bill directly at the end when we have our Q&A session. Thank you. So without any further delay, Bill, over to you. Bill, I think you're muted. I can't hear you at least.
You hear me now?
Yes, we can. Thank you.
Excellent. Not sure what it says. It wasn't muted, but you never can trust these things. Thank you very much. And thanks very much for the invitation. First of all, start with my declaration of interests. I am now retired, as Jacob said, and so sadly, no companies want to give me vast amounts of money. I am grateful to Prof. George for the kind introduction. There are indeed a few achievements I'm proud of. Top of the list, of course, was having been co-chair of SHARP a few years ago, but mostly I'm now a has-been. I would like to acknowledge the influence of this gentleman. Jim was my mentor, a founding member of SHARP, and a friend who we sadly lost earlier this year. His influence lives on. Jim worked with another friend and mentor, Chris, who you will recognise as a current trustee. The importance of their work on cholesterol metabolism should not be underestimated. It has led to the improvement of cardiac health of millions of people worldwide. The topic of this session is cholesterol, how to treat it and when to refer. But first, let me take you through a walk through the lipid forest and tell you a little bit of the story behind cholesterol. So my granny had cholesterol. It didn't make her sad because, though high, unlike the wolf, it wasn't all that bad. By the end of the session, I hope to have let you get to know cholesterol a bit better, when it needs treated, and how to treat it, and where more help may be needed. Okay, we know that there's a relationship between cholesterol and coronary heart disease. Each extra millimole of cholesterol seems to predict 20% more coronary heart disease. But it's not that straightforward. Clearly, in Japan and Mediterranean Europe, at this time, the relationship was not 20% more risk per millimole. Also, whilst both cholesterol and coronary heart disease rise with age, the association between the two actually lessens with age. Indeed, by the age of 80, a higher natural cholesterol is actually associated with a longer life expectancy, even in FH. It also depends which lipoprotein the cholesterol is in. If there's a reasonable proportion in HDL cholesterol, the total cholesterol appears less harmful. There's also an interaction with triglyceride. High normal triglycerides are associated with a higher risk. To understand why, we need to look at lipids in slightly more detail. There are two main types of lipid, sterols and fatty acid derivatives. Sterols, including cholesterol, have various vital roles controlling metabolism. The roles of the fatty acids include very efficient energy storage. Free fatty acids have a polar end and can be transported bound to albumin, but the majority are bound to glycerol. Two fatty acids bound to glycerol, along with one phosphate, will form a phospholipid, or three fatty acids bound to glycerol form triacylglycerol, which we'll know better as triglyceride. Triglyceride has no polar regions at all, so it's hydrophobic. In other words, it doesn't mix with water. Likewise, cholesterol esters have no polar region and don't mix with water. So if you pour triglyceride, for example, vegetable oil, on water, on a water-based fluid, for example, vinegar, it will simply float on top. However, if you add oh, sorry, there's the mustard, then it will interface with the aqueous fluid because of the polar bit. And if you give it a shake, it will form an emulsion. And if you whisk in some cholesterol, for instance, egg yolk, you could even make a nice mayonnaise. Phospholipid can, of course, line up in a bilayer separating two aqueous compartments, i.e. a cell membrane, and cholesterol can intersperse to give some stability. The significance of a micelle is that it is the way triglyceride, oil, has to be transported in blood, which is water. The body needs handles to be able to move these lipid structures around in blood, and so specific proteins are incorporated, forming a lipoprotein particle. Different types of lipoproteins have different apolipoproteins, which can be recognized by protein receptors. For example, the LDL particle can interact with LDL receptors in the liver. Lipoproteins come in a range of sizes, containing varying proportions of cholesterol and triglyceride. The huge chylomicrons are formed in the gut. They transport, transport dietary fat to the thoracic duct. Oh, it's moving on without me asking it to, sorry. They transport dietary fat from the thoracic duct and into the blood, from the gut through thoracic duct and then straight into the blood. And you can occasionally see chylomicrons as the cream floating on top of blood samples. Right, now we should move on. So the liver will convert any excess carbohydrate and protein into fat for storage as energy. In doing so, it creates triglycerides and packages it in lipoprotein particles for transport to the fat stores. A large proportion of the triglyceride makes them float because they're very much less dense than water. Hence the term very low density lipoprotein. As it goes around the body, triglyceride is removed by the tissues. Cells has a role in reverse cholesterol transport. And as we saw earlier, higher levels of HDL are associated with lower coronary heart disease risk. So with this large variety of lipoproteins in the body, which are actually measured in the routine lab, and hope you've got a pencil and paper ready to jot down some answers. In this case, none of them. We don't measure any of these. Clinical labs measure all the cholesterol in all the lipoproteins at once, and the same for triglyceride. Triglyceride can vary hugely with diet, however, so if triglycerides have been raised, asking the patient not to eat or drink for 16 hours can allow chylomicrons to clear, giving more consistent results. The amount of intermediate density lipoprotein is also usually quite small, so we can pretty much ignore that at the moment. The main particles in fasting blood are VLDL, LDL, and HDL. So effectively, we're left with three main particle types. We can measure the cholesterol present in HDL specifically, so most of the rest of the cholesterol in blood, i.e. the non-HDL cholesterol, will be in VLDL and LDL. Most of the triglyceride will be in VLDL and LDL, with the distribution being fairly predictable in fasting blood. Just under half is in LDL. So from that, by measuring the total triglyceride and cholesterol and the HDL cholesterol, we can calculate the LDL cholesterol using a method called the Friedewald formula. It doesn't work if the triglyceride is raised because it means there's other particles there. So sometimes if you ask for an LDL from the routine lab and it comes back saying we can't calculate it because the triglyceride is too high, it doesn't mean that the LDL is very high necessarily. It just means that that formula doesn't work anymore because there's other particles there. But it isn't quite so simple. Each of these different particles comes in different sizes. And the importance of that, well, lipoproteins can move across the intima of coronary vessels, but those of a certain size, especially if they get oxidized, can get stuck, and they can attract inflammatory cells, resulting in atheroma. The small, dense form of LDL is particularly prone, and so it's got a stronger association with atheroma. Okay, that's fairly heavy here, lipid biochemistry. Now, by way of light relief, here's a picture I took of the Li River in China. I was amazed by the shapes of the mountains. You see them in cards, but you don't believe them. But yeah, they're true. They are just straight up and straight down almost. Indeed, this particular one in the background here reminded me of a low-risk LDL subfraction pattern with a relatively small amount of small dense LDL. The distribution of LDL subfractions can be seen by separating them on a gel. And from this, we know that people with a lot of the small dense LDL, for example, an insulin resistance, have the highest risk. And here's the first wolf. But we don't need complex measurements using chromatographic gels to work out. We can actually use the basic lipid profile. The triad, as it's called, of raised LDL cholesterol, a low HDL cholesterol, and a slightly raised triglyceride tends to reflect a higher proportion of the small density LDL and is particularly high risk. Fortunately, to some extent, the assign and Q-risk scores capture this by using HDL cholesterol in the formulas. So, okay, time for a break. Pen and paper at the ready. Quickly write down for me what you think is the answer. Now, obviously, having coronary disease already is the strongest predictor of having coronary disease in the future. So, apart from that, if you're only allowed to make one measurement to predict the likelihood of developing heart disease in the future, what would it be? You can choose from smoking, blood pressure, diabetes, cholesterol, or you could specify something else if you're choosing. Okay, have you chosen? Okay, so it's going to be something else, or else this would be a particularly pointless slide. All of these are very important individual risk factors, but don't give the strongest prediction of heart disease. If I show you a map of coronary heart disease in Scotland, and then superimpose typical rainfall, yes, as a single measurement, the amount of rainfall in your locality can give one of the strongest predictions of future coronary heart disease. This is from a paper back in 1981. Fascinating. Now, don't be tempted to spend the rest of the time working out how rainfall causes heart attacks. It doesn't. The moral of this is that an association, even a strong association, is just an association. It's not the same as causation. And with cholesterol, we know that there's an important association with coronary heart disease. But cholesterol is also modifiable. And we know from many intervention trials that reducing it does reduce risk. So we can be reasonably sure that in this case, there is causation as well as association. When interpreting cholesterol trial data, however, as with any headline-grabbing trial, it's important to read the small print, in particular to know which population has been tested and which outcomes were actually measured. And we still need to be wary of surrogate measurements such as a change of LDL being interpreted as a reduced event rate. Now, the benefits of statins, however, are beyond doubt. And so many guidelines were developed based on the Framingham data to identify people at risk who might benefit from statins. You may remember the charts at the back of the BNF. Now, more recent trials have shown benefits of treating lipids with agents other than statins. Some 14 years after ezetimibe was initially used across Scotland, the Improve It trial finally provided some evidence that it does help to reduce events. More recently, Osler showed a reduction with evolocumab and Odyssey with alirocumab. These are the fortnightly PCSK9 injections you may have heard of. And much more recently, Reduce It suggested significant benefit from icosapent ethyl, which I don't expect you've heard of yet. It still awaits consideration by the SNC, but it may be coming to somewhere close to you soon. Outcome data is yet to be published for the 6-monthly PCSK9 inhibitor inclisiran and for bempedoic acid. So we don't have outcome data for them, but they have both been approved for restricted use by the SNC. Statins, however, remain by far the most cost-effective available treatment to tame the wolf. Which is why the SIGN 149 recommendations, old as they are, regarding the use of statins remain relevant. If atorvastatin causes problems, try a different one. Where there's no existing coronary heart disease, SIGN doesn't suggest any other alternative statins, because no other class of medicine has been shown to be of benefit for primary prevention. Oh, sorry. In secondary prevention, though, they do recommend alternatives, including ezetimibe, if people are intolerant of statins. So I made a quick word about statin intolerance. Statins are the best-selling drugs of all time, and they are really pretty safe. But a few caveats. Always check baseline bloods before starting statins, because you don't get a chance to see what they were like before you started the statin if you don't check them before you start the statin. Particularly liver function. I personally, well, in the BMJ also, in the BNF, sorry, also recommends that you check thyroid function beforehand. I personally always recommend rechecking the lipid profile again, especially the last couple of years when they've been very variable with COVID. But also I usually prefer to get a CK if anyone's got any hint of muscle problems. But anyway, always check the routine baseline blood. Significant side effects are rare, but perceived side effects are common. And patient confidence in this area is vital. Patients need to be reassured that statins are the most effective way to reduce risk, that different statins behave differently, and so if you need to reduce your risk, it's usually worth trying another statin. For intolerance, in the secondary prevention SIGN, as I say, it says to try ezetimibe for secondary prevention if intolerant to all statins. One suggestion I intend to make to SIGN for the next update is to consider establishing on ezetimibe before trying any alternative statins. It may not seem to reduce the LDL cholesterol very much, but it does help to reduce the rebound high cholesterol which you would get with the next statin, but it wasn't tolerated either. And that rebound high cholesterol may be a problem. A quick word on ezetimibe. Most importantly, patients need to know that ezetimibe is not a statin, so it doesn't have any statin-related side effects. It simply reduces gut absorption of cholesterol, so the liver tries to compensate by taking in more from the circulation. It has been associated with around 8% fewer events, so not as potent as any statin, but probably better than nothing. I say probably because the trial evidence of reduced events has all been when given in combination with a statin. In that context, it appears to reduce coronary disease events regardless of the amount of LDL lowering, probably because the LDL is already low because of the statin. But clearly, statin plus ezetimibe will reduce events, and it does reduce events more than statin alone. A word about the newer agents. SIGN has not yet been updated with recommendations regarding the newer agents, but as mentioned, the Scottish Medicines Consortium have conditionally approved PCSK9 inhibitors and bempedoic acid. Uptake into local formularies and guidance isn't consistent across Scotland, however. Now, social media will have you believe that PCSK9s are fantastic. Patients should be aware that the outcome evidence is not as strong as it is for statins. PCSK9s are not meant to replace statins. The best outcome evidence is found in the combination. Bempedoic acid, in combination with ezetimibe, has been approved by SMC for statin intolerance, where ezetimibe alone is insufficient. But there's no definition of what insufficient means. It doesn't as yet have any outcome evidence in humans, though it has induced regression of disease in animal studies. It is important to remember that, whilst other classes have been tried, nothing has better evidence of protection than being on any dose of any statin. And as I say, unfortunately, that's not the impression given in the media. Now, once on treatment, how do we decide whether it's working? SIGN 149 cautiously avoided giving targets, but around that time, 4 for total and 2 for an LDL were fairly typical ones at a time. Targets, however, do tend to keep moving. Remember the 7 countries study? That target of 4 millimoles per litre might work in Northern Europe, but it would do nothing for Japan. So much depends on the population, which is why it's important to know the populations of the various trials. Remember that statin meta-analysis. The prevailing interpretation is that there will be about 20% fewer events for each millimole reduction of LDL cholesterol. But if you focus on the trials which aimed to reduce LDL by 1 millimole, the observed benefit varied from 10 to 40%. The benefit depends on the population and indeed the subpopulation of those trials. Now, if we focus on the 4S trial for the moment, that's the very first statin trial. It was the first statin outcome trial, and its population was very high risk, statin naive, and so it's no surprise that they gained the most. But even then, if you separate out only those individuals with the lipid triad, remember that move? Simvastatin reduces the risk considerably. However, if you look at only those who didn't have the wolf, who had a high LDL but not the full triad, they gained much less from simvastatin. So the greatest benefit comes from treating high-risk patients with the full lipid triad, i.e. a low HDL, borderline trigs, in addition to the raised LDL. And indeed, from this data, one could argue that a raised LDL cholesterol on its own did not significantly increase risk, even in secondary prevention. It isn't always easy, however, to spot the wolf, but we do know that statins are safe, so it's easier to offer statins to all who might have the triad. Now, from that, I hope you can see that it's difficult to specify one target for all, so I think SIGN was justified not having targets. But nevertheless, targets were recommended by other guidelines across the world, including NICE. And now even newer, lower targets have been fairly widely recommended. Ones that you can't really even achieve if you don't use PCSK9 inhibitors, even though there's no evidence in these situations necessarily. And so it remains to be seen what SIGN will come out with when it's next updated. So no specific targets in SIGN, but as I said, the Scottish Medicines Consortium effectively have produced targets as such. For specified populations, there are LDL thresholds for the use of the PCSK9s. In people without coronary vascular disease, but at high risk, in other words, in familial hypercholesterolemia, if they're above 5 millimoles per litre on maximum other therapy, then they merit treatment with or consideration of treatment with the PCSK9. Or people with coronary vascular disease and LDL persistently over 4, or recurrent coronary vascular disease with a LDL over 3.5. So people in that situation would be worthy of consideration for PCSK9. For bempedoic acid, as I say, there's no LDL threshold actually specified. Now, I mentioned FH again here. So it is time that I introduced the other wolf lurking in the background. That thing about an isolated high LDL not being a risk, well, while that's true for the general population, it isn't true in FH. So we need to know a bit more about this wolf. Remember that the liver distributes triglyceride to the stores and tissues in VLDL, and the triglyceride is removed, leaving LDL, which gets removed by the liver. And the ApoB on the LDL particle is recognized by the LDL receptor. The LDL gets taken in and disposed of. And usually the receptor moves back out to the surface of the hepatocyte to take in more cholesterol. But mutations can occur in the LDL receptor, which then can't recognize the ApoB. Mutations can, stuck on there here. Mutations can also occur in the ApoB itself, so it can't be recognized by the receptor. In either of these cases, remember that for heterozygous FH, half your protein will be the mutated protein and half will be the normal protein. So you still get some recycling, but it's just slowed down. Either way, the LDL isn't cleared as effectively, resulting in exposure of the coronary intima to a high level of LDL throughout life and a markedly increased heart disease at a young age. Until recently, it was thought that 1 in 500 people had FH. And half of those affected by FH developed coronary heart disease prematurely. But we now know that it's almost twice as common as we thought. Thousands of different mutations have been found in the LDL receptor gene, and it may be that some mutations are not quite as dangerous as others. But there is no doubt that it's still an important preventable cause of premature death. Because if taken regularly, statins remove this excess risk entirely. Treatment is therefore straightforward, but it is most effective as prevention rather than as cure. And often the first sign of FH in a family is the first MI in a young person, which could well be fatal. So it's better to find out early. Smoking advice and avoidance is crucial from throughout life, and that lifestyle choice is best enshrined before the age of 7. For some reason, if you tell them not to smoke before the age of 7, they don't. But people after the age of 7 told not to smoke, they do what they fancy. So that's another reason to find out early and get advice early. It's best diagnosed by genetic testing. And this gives a much more definitive diagnosis. And unlike just checking lipids, a positive test can be cascaded to definitively find those 50% of blood relatives who will also have FH, including testing children of any age. But who should we test first? Well, firstly, there can be clinical signs. However, whilst the presence of premature corneal arcus or xanthelasmata or of eruptive xanthomata should certainly stimulate checking a lipid profile, they're not particularly suggestive of FH. Indeed, xanthelasmata may be more suggested, may be more frequent in liver disease. And I've seen eruptive xanthomata most frequently in undiagnosed diabetes, with the triglycerides being high. On the other hand, tendon xanthomata, whether knuckle, patellar, or Achilles, are all highly suggestive. And if you come across these, you should test for FH. These signs are, however, relatively rare these days, so we need other pointers. Well, it's a familial problem, so a family history is really quite important. But it's not very easy, especially in Scotland, where almost everyone has a high cholesterol and some have heart disease in the family. So the family history is only relevant if it's premature. And by that we mean before the age of 50 in males or 60 in females. So somebody's father having a heart attack at the age of 51, for instance, wouldn't be particularly suggestive of FH. Whereas if their mother developed heart disease at 51 and had an LDL cholesterol of 6, we would be much more suspicious. It is perhaps surprisingly difficult to diagnose FH by lipids. It's usually just the LDL cholesterol that's raised, and typically to greater than 5, although there is a wide overlap, even in younger people where the discrimination is better. And if the trigs are raised more than 3, FH is less likely because it means that there are other particles there accounting for some of the cholesterol. And if trigs are more than 5, then there's usually another problem needing attention. It's usually secondary to something else. Also, as a lifelong condition, if LDL cholesterol was previously lower, then FH is unlikely, because the FH would have been high throughout life, unless the lipids were measured when the patient was unwell. Even people with FH, if the cholesterol can drop right down during an acute phase of illness. So if somebody's unwell for any other reason, don't check the lipids at that point. Check it every other time, but not when they're unwell. The other thing is that looking at having a list of previous cholesterol measurements is very useful, because you can tell if it's been varying a lot. You can get some indication of what it's secondary to. Because dyslipidemias are often secondary. A few common pitfalls when trying to diagnose FH. Difficulties often arise because of secondary dyslipidemias. Often the trigs are raised, but not always. So whenever a dyslipidemia is found, possible secondary causes should be looked for before starting lipid lowering. And there are so many. There's a lecture all on its own talking about secondary dyslipidemias, but the obvious ones: liver, thyroid, and diabetes, proteinuria, and also many medicines these days. I would say at one point, a couple of years ago, I would say 10% of the referrals to my clinic were people who were taking mometasone nasal drops. And that can be enough to put your cholesterol up by a millimole, but not in a bad way. Because quite often the raised cholesterol from medicines, including any kind of steroid, including SSRIs, tends not to increase the cardiovascular risk. Certainly not to the extent that FH does. So I wouldn't recommend changing these medications. Just be aware that they can push the cholesterol up, and it doesn't make it FH. Again, previous records are useful to work out, if a medicine has caused it. But if in doubt, then it's time to call the woodcutter. Although you may have local guidance in various from the various clinics around Scotland, and that's probably a useful starting point. Now, let me very briefly mention another wolf you may hear about before too long. Lipoprotein little a, or LP little a for short, is a bit like the LDL particle, but probably a lot more aggressive. It is higher in some secondary dyslipidemias, and there's also a rare inherited form which behaves very much like FH. It doesn't constitute a large proportion of the cholesterol, and so it can be a risk even when the cholesterol is not particularly high. But LP little a isn't routinely measured out with lipid clinics at present, and there's no treatment, no specific treatment to offer it either, other than intensified standard therapy. But there are ongoing trials of a novel agent which can treat it. And so if that's successful and reduces events, you will be inundated with requests to get your LP little a checked. Watch this space. So, when to call for the woodcutter? There are three main reasons for referral. The help with diagnosing and treating primary dyslipidemias is probably the most frequent reason for referral to the lipid clinic. Statin intolerance or statin ineffectiveness are the other two main reasons. So let's look at these in turn. The diagnosis of primary dyslipidemias, including FH, well, we've talked about the LDL. If you get a confirmed LDL greater than or equal to 5, then certainly look for a typical family history and for previous historical values, but in general, they could be worth considering referral for further advice. And triglycerides, not pointed towards FH, but could point to other inherited problems. So a triglyceride, which if it's consistently over 10 millimoles per litre, above which there's a risk of pancreatitis, then I would confirm it with a fasting profile, but consider referring in. There are some newer treatments for triglyceride, but the conditions for which these are really recommended are very rare. Familial chylomicronemia syndrome, for instance. But as far as I know, there are only 2 people in Scotland with that as yet. But as I say, in each case, always look for a secondary cause first, because treating the primary cause of a secondary dyslipidemia will usually improve the lipids, but also may suggest alternative ways of treating the lipids. Also, the true primary dyslipidemias may require, as I say, non-standard lipid lowering, which may be managed at least initially in the clinic, and so that's the reason for referring in. Also, if a genetic cause is found, then the local genetics clinic can usually carry out cascading to relatives to find more people without waiting till they appear with heart disease. Statin intolerance. We've already talked a little bit about statin intolerance. And before referring or trying alternatives, I would suggest checking various things. Check the thyroid function and the CK enzyme. It may have been checked before, but it might have changed. One of the common reasons, statin myalgia is much more common in thyroid dysfunction. So it's certainly always worthwhile checking the thyroid. But I would check the other things as well. Now, as suggested, as I suggested before, perhaps establish on ezetimibe and continue it while trying alternative statins. But there are 5 statins to be tried. It's rare to find people who are genuinely intolerant of all statins. Now, in this list here, I've left simvastatin in brackets because it is quite similar to atorvastatin pharmacologically, and so it's perhaps better to try others first. But if none are tolerated, then for primary prevention, as I say, there's no other evidence-based option. Patients should continue with lifestyle and dietary measures, but there is no need to call for help. For secondary prevention or patients with FH, there may be alternatives available, so referral may be helpful, but statins should be continued if at all possible, even at low dose, if that's all that's possible. Now, one other thing you may come across in statin intolerance, some practitioners, particularly in Canada, recommend taking over-the-counter food supplements. Both vitamin D and coenzyme Q10 have been recommended. And I still recommend them to patients sometimes. If I suggest Q10, I say go and buy some in Tesco's. So that's the cheapest. Other places are available, but that's the cheapest I could find, 100 milligram daily. The evidence is lacking. But if it helps somebody to take a statin when it's needed, then the evidence that the statin works, it may make it worthwhile. Excuse me. Remember that SIGN haven't stated targets, and for primary prevention, there'd be no need to refer. For secondary prevention, while SIGN doesn't state targets, SMC have approved the PCSK9s for use if the LDL remains over 4. But remember that local guidance, local guidelines and availability may vary. Now some final thoughts. Lipids are best checked yesterday. Having historical records of lipids is so useful when you're trying to assess the current lipid profile. And for that reason, if you look behind me, you'll see boxes and boxes. These have got old lipid levels in them that aren't available electronically anymore. And although I've retired and these are about to be destroyed, we have no way of keeping them. It's rather a shame. But I'm persuading my colleagues to keep a hold of them until my successor arrives, just in case my successor wants to look at previous ones. So for that reason, I usually recommend not to be afraid to offer lipid measurements to any patients getting routine bloods done for other reasons. Now, don't let my laboratory colleagues tell you that I said this. Let you know that. Don't tell them that I said this, because they won't like it. But anyway, if you're getting bloods done for other reasons, it only adds pennies to do lipids as well. And if you're taking a sample anyway. But it could save a huge amount in the future, avoiding unnecessary investigation and treatment if you had previous cholesterol to go on. And just occasionally you may find one which genuinely does need treated there and then to prevent future events, and that will save thousands. But since we've stopped measuring routine cholesterol measurements as part of well-being, indeed, I checked again with my own general practice just last week to see if that they would check my cholesterol for me since I'm over 60, and they said no, we don't do that anymore, which almost reduced me to tears. I have to say, it reduced many of my patients to tears when I asked this question in my practice a few years ago, and I let my patients know that my own practice wouldn't check my cholesterol. They found it very amusing. Anyway, so if you're checking bloods anyway, as I say, it might add £1 to the estimation, but it costs about £10 to check a sample for anything you're doing. And it costs you in time much more if you need to go back and do it another time. Anyway, enough of that. I'll go off my high horse here. For low-risk patients, a statin, a low-dose statin, 20 milligrams of atorvastatin, is all that's needed. Still encourage patients to follow healthy lifestyle options, but don't worry about the numbers. If it's down, and they're taking, which means they're taking the statin, that's fine. Doesn't matter how much it goes down. If they're not taking the statin, that's a different matter. You know, non-adherence to statins is about 30%. And that's worthwhile having a chat about. After all, the most expensive medicine is the one that's just poured down the toilet without using it at all. For higher risk patients, then yes, titrate up the statin if possible. But remember that a lower dose is better than no dose if tolerance is an issue. And finally, Granny may stay in a wood-infested forest, but she has survived so far. If a high cholesterol hasn't caused harm in 75 years, it's unlikely to do so now, even in FH. The only benefit demonstrated in older people has been for secondary prevention. And here, patient choice is paramount. To take a statin or not a statin is the patient's choice. Thank you. That's all I wanted to say this evening, but I'm happy to take questions. And I'll try to stop sharing my screen if I can get to my...
Thanks very much, Bill, for that very interesting and wide-ranging talk about lipids. So if I can encourage those in the call, if you've got questions, please raise your hand and ask them, or just type them in the chat box. Bill, we've got a question from John Love in NHS Grampian about what you just mentioned right at the very end there, about recommending statins as a primary preventative measure for older patients above the age of 60. Okay. You've already commented on that, but any further thoughts?
Well, the sign 149, I still think are correct. If it's primary prevention, then statins are the only medicines which have been shown to be a benefit. So if you can take a statin, fair enough. If your sign score is high, if you've got a high risk, and it's going to be high because if you're that age, it will go up. And for that reason, in England, they don't recommend bothering. They just say give everybody over the age of 80 a statin because their risk is so high. But in Scotland, we like to go on evidence, and there is actually no evidence of any benefit in outcomes. Yes, you can reduce the LDL, but there's been that doesn't transcribe into benefit in terms of outcomes. No trial has shown that. The best trial was one that Jim and Chris did, the PROSPER study. I don't know if Chris is here today, probably not. He'd be better answering this question than me, but the PROSPER study showed a benefit in people who had existing heart disease, but showed no benefit in people who had for primary prevention. So whilst statins are relatively safe and cheap, they may be of some benefit and they're worthwhile trying. But if people have any problems with them, I go with the patient's choice. If they don't want them, that's fine. But I wouldn't recommend something like a PCSK9 or anything else for people who haven't been shown to be a benefit. I just don't think that's right. Does that answer the question?
I think it does. I hope, John, I hope that answers your question. We've got a question here from Manish Kaur, also from your neck of the woods. Are you confident that any of the current risk calculators take ethnicity sufficiently into account, particularly South Asians and Southeast Asians?
Good point, Nash. Very good point. And I think the hope is that the next iteration of SIGN will change a SIGN to take account of that. You're quite right. The risk is vastly underestimated. But for that reason, yes, a SIGN sets a check to offer a statin to people whose risk is over 20, but most people, I think, will offer a statin when it's even between 10 and 20 when they're on the assigned score, partly for that reason. As for the degree of benefit, it's difficult to know. But there is also, as you know, a higher incidence of insulin resistance. And perhaps part of the reason that a SIGN underestimates the risk in the South Asian population particularly is because more people in that population have the wolf. There are more people with the slightly high triglycerides, the low HDL, as well as the raised LDL. And so that's perhaps why the risk is higher than it might be predicted. So I quite agree.
Thanks, Bill. I'll follow on with that while I wait for another question to come up. So you mentioned low HDL, and you know the CETP inhibitors have all failed in clinical trials so far. How do you manage patients with very low HDLs? What do you tell them to do? Well,
they're the ones who benefited from statins and 4S and so on. I mean, the HDL trials is one of the reasons why we hear so much about outcome trials. For those who don't know, there were these. We've thought HDL for a long time has been a great thing, and you should have more HDL. But in fact, it's your natural HDL that's the important thing. Having a good HDL is good. Pushing your HDL up is not good, and it could be because you're pushing up HDL that doesn't work as well. So if you can get your HDL up, for instance, with exercise, excellent. With weight loss, excellent. but there is no, as yet, no drug which has been shown to increase your HDL that improves outcomes.
Okay, great. Thank you, Bill. Justine, you've got a hand raised. Do you want to come in?
Yeah, hi there. Yeah, I hadn't heard of the vitamin D and the coenzyme medication
Q10,
previously, yeah, Q10. So is that in relation to helping improve somebody who's intolerant of the side effects of statins? Or
as I say, I did try to stress that there's no evidence for these. In fact, there's a Cochrane review which said there was no benefit. However, that was a tiny review based on 3 trials. I know, well, I had anecdotal reports from colleagues in Newcastle and Birmingham who had done trials with coenzyme Q10 and thought it worked, and they never published the results. And between the 2 of them, they would have more of a population than the entire world literature. However, we are faced with the fact that there is no current evidence, which is why it's not available as a prescribable medicine. It is routinely used in Canada, even though there isn't much evidence for it. But the importance is just what you were saying. The importance lies in getting or enabling a patient to take the statin. To my shame, I do have one patient who liked coenzyme Q10 so much that he carried on taking that, but still stopped the statin. People make their own choice. But if you can get somebody to be able to tolerate a statin, whether it's a Q10 or vitamin D, that's fine. Vitamin D, there was some evidence that very low levels can increase the risk of rhabdomyolysis. It's tenuous, but there is some suggestion there. And you know, as the you know, in Scotland, almost everybody is vitamin D deficient. So you know, you could argue for taking some vitamin D supplements, but I haven't ever been aware of it actually enabling people to take statins. But it is worthwhile making sure that, or suggesting to people that they try it anyway, because they'll be taking it anyway.
Hope that answers your question, Justine.
yeah, thank you. Sorry if you had my dog in the background.
Oh no, I'm just pondering the fact that you can probably hear the seagulls in the background here, which is from sunny Aberdeen.
Great. Bill, we've got James Lambie who is asking about why SIGN prefer a SIGN over Q-risk, because Q-risk, obviously, as you know, takes a lot of other factors into account, other drugs, etc. Yes.
Well, Q-risk. Now, there is a great individual in Tayside called Professor Hugh Tunstall-Pedo. Many will remember him. And indeed, at the last SHARP meeting, he very kindly gave me one of his Dundee risk discs. I don't have it with me, unfortunately. Before the use of the Framingham data and the SIGN and the Q-risk scores, Tunstall-Pedo had brought out this mechanism for predicting future risk to work out who to treat. Now, when Q-risk was first published, it used data from all EMIS practices, mostly in England, a little bit in Scotland. And the data was questionable to the extent that Professor Tunstall-Pedo did actually question it. And if you read the original Q-risk paper in the Lancet, Professor Pedo's letter is the first one to be published. And mine was the second, because they made up's the wrong word, imputed is the correct word, imputed some of the data. So you know, on average in the population it will work because it's fairly crude, but Q-risk wasn't necessarily perfectly tailored to the Scottish population. And then when Q-risk 3 came out, when Q-risk 2 came out, it actually dropped all the Scottish data completely. So it's only based in England. I did ask the lead author why Scotland was dropped from Q-risk 2 for Q-risk 2, and he said, "Oh, we found it easier to forget about the Scots." That's a direct quotation. Anyway, a SIGN was based on a Scottish population. It also takes into account deprivation, which is very important, particularly in Scotland. So in my view, a SIGN is still a better score than Q-risk. Neither of them are perfect. Neither of them will predict the person who is going to have a heart attack. It just tells you the kind of people who might in the future. Neither of them are perfect, but it's something to go on.
Bill, you've courted some controversy here. I've
No.
got Suzanne McKenzie, who we know well. She's unsettled by the idea that you said you should check lipids incidentally when doing other bloods. Suzanne, I don't know whether you want to come in. Perhaps you could. Surely the risk of finding mild abnormalities and causing anxiety, giving unnecessary treatment outweighs the benefits, Suzanne says.
Suzanne, you're absolutely right. You're absolutely right. There is that, of course. But on the other hand, not checking it and not knowing it and not knowing what it was before, I think is possibly slightly worse. I think we should check it far more often and be much more relaxed about it and let our patients know that we're relaxed about it. We're just checking this for 20 years' time. That's my view, personally. But there we go. I fully accept that, setting somebody down a train of investigations and possible treatment is not ideal at an early age, but it is. The other thing, though, it is less likely to be a false positive the earlier you treat. I mean, bear in mind David's data in the children, where he found that the best time to check a cholesterol is in infancy, because that's the best differential between FH and non-FH. So, I don't know. Yes, it's controversial, I agree, which is why I said it tongue-in-cheek, and why I said not to let anybody from labs know, which is why you shouldn't have been listening to that bit, Suzanne. Okay, good. Fair point. But the other important point was not to check cholesterol when somebody is unwell, because that will give you the wrong answer completely, even in FH.
Absolutely. So I can't see any further questions. Bill, maybe I might ask you one more. Your thoughts about putting patients on statin holidays and re-challenging them if they present with muscle-related complaints on statins.
Well, there was actually a very good a paper published on statin myology just 2 weeks ago, which of course I shouldn't be reading because I'm retired, but it goes through all this, and it found that people who were re-challenged, very, very few actually had the same condition, the same problems. And whereas, well, shall I say very few, many people do have the same problems, but even if what you're challenging with is a placebo, the nocebo effect is just as strong. So much of statin intolerance is patients' perception, and it's so difficult. That's why it's so important to get their confidence in the first place. And once the confidence is lost, it's very difficult to persuade people that statins are a good thing. But the re-challenging, as I said, I would prefer people to be on ezetimibe before stopping and starting and stopping and starting. It took me 20 years to get the paper out about the statin, about cholesterol variability being important, but it is important. And cholesterol, I didn't go into this in the talk because it would take up too much time, but cholesterol variability can be as important as the total cholesterol, even in the Framingham data, and showed that. So a cholesterol bouncing about can actually cause, a rising LDL cholesterol can actually cause an influx in inflammatory cells into the coronary intima within a few weeks and possibly precipitate an acute event. And that's based on observations from a few people back in the early days of statins who had statins, high-risk people who were on statins and stopped them because they couldn't tolerate them, and they got another event within 2 weeks of stopping the statin, and that seemed to happen fairly frequently. So for that reason, I prefer people to be on ezetimibe, if possible, before you stop the statin. I mean, if you've got muscle aches and pains, okay, yeah, you're not hiding to nothing, but if you can be on a statin, on ezetimibe first, because it stops that rebound high cholesterol. I have no evidence behind that as yet. It's never been tested in a trial, but it seems to make sense. And possibly that's why ezetimibe works. I don't know. We just don't know.
Great. Thank you, Bill. I can't see any further questions. Just to remind people that the ESC is going on at the moment in Barcelona, and on Monday, the Cholesterol Treatment Trialist Collaboration will be publishing a paper in the Lancet. I'd encourage you to look out for that, and that relates to statins and side effects. It'll be a very fascinating paper that's going to come out. It'll probably be in the news as well. Yes. Okay. Two other bits of housekeeping rules. News. One is those who've requested attendance certificates. That will be slightly delayed because Shirley, who is our administrator, is going off on well-deserved annual leave. So when she gets back, she will make sure that you get your attendance certificate. And secondly, can I just remind everyone about the annual scientific meeting of SHARP? And I'm just putting up the slides, and I hope you can see it. And that really is going to be a culmination of all the different talks that we've had really over the years with regards to cardiovascular risk management. And we've got fantastic keynote speakers, both Sir Rory Collins and Professor Roxana Meran from Mount Sinai, who will speak to us on various aspects of cardiovascular risk management. So if we can encourage you to sign up for it, the QR code is there for you to scan if you're interested. And it's a hybrid meeting, so you can attend both online and in person if you wish. It's at the Royal College of Surgeons on the 17th of November. And also, if you've got any data, any audit, anything interesting in terms of scientific research that you're involved in, that you'd like to present as an abstract and perhaps stand a chance of winning the SHARP prizes, then the details are there in front of you also, and you can scan that QR code to get more information, or go to the SHARP website at sharpscotland.org. So with that, I'd just like to thank Bill once again for that excellent presentation, and thank you all for attending once again. Hope you found this useful. Those of you who want an attendance certificate, please would you email the SHARP office? You should have that email. It's the same email that sent the information for this webinar as well. So if you could just email the SHARP office and request a certificate, surely will ensure that you get it. Thanks very much once again, and have a good evening. Bye now.
Thank you.